We've received apologies from Deputy Maura Devine and Senator Nicole Ryan, and it's understood that Deputy O'Muraku will be substituting for Deputy Devine for a number of weeks at least. I'm really delighted today to open the 10th public meeting of the Joint Committee on Drugs. In today's session, we're going to be focusing on substance use and neurodiversity. And I want to particularly welcome our witnesses today, our expert witnesses today, Mr. Ken Kilbride, who is the CEO of ADHD Ireland, Dr. Sonia Morris, who is a board member of ADHD Ireland, Professor Catherine Comiskey, who is Professor of Healthcare Modelling, Global Addiction and Transformation at Trinity College Dublin, and Mr. Philip James, Assistant Professor of Mental Health Nursing, Trinity College Dublin. You're all very welcome. Thank you for attending today. I'm going to read a short note on privilege before we begin. So all witnesses and members are reminded of the long-standing parliamentary practice that you should not criticise or make charges against any person or entity by name or in such a way as to make him, her or it identifiable or otherwise engage in speech that might be regarded as damaging to the good name of the person or entity. Therefore, if your statements are potentially defamatory in relation to an identifiable person or entity, you will be directed to discontinue your remarks. It is imperative that you comply with any such direction. I'd also like to remind members of the constitutional requirement that in order to participate in public meetings, members must be physically present within the confines of the Leinster House complex. Members of the committee attending remotely must do so from within the precincts of Leinster House. This is due to the constitutional requirement that, in order to participate in public meetings, members must be physically present within the confines of the place where the Parliament has chosen to sit. In this regard, I would ask any member partaking via Microsoft Teams that prior to making their contribution to the meeting, that you confirm that you are on the grounds of the Leinster House campus. All opening statements have been circulated to members and will be published on the Oireachtas website after this session. And as agreed, we'll limit each opening statement to 5 minutes to allow plenty of time for questions and answers. And I'm conscious that a wide range of issues will be discussed today. If necessary, further, more detailed information on certain issues can be sent to the clerk of the committee for circulation to members. I should also mention that members will be in and out of the committee room during the meeting due to other parliamentary commitments. I understand that Mr. Kilbride and Dr. Morris are sharing time, and I now invite them to deliver their opening statement on behalf of ADHD Ireland.
Thank you very much. On behalf of ADHD Ireland, we would very much like to take the opportunity before we begin to thank the Chair and members of the Joint Committee on Drugs Use for giving us the opportunity to present to you today. To start, let's put ADHD in context. ADHD is a neurodivergence which is primarily genetic, so it tends to run in families. It's a difference in how brains develop, which means it influences how you experience the world. It also means it doesn't disappear on your 18th birthday, and for some, it can impact their function to various levels across the entire lifespan. Medication is available for ADHD, which supports the functioning and is a recommended intervention in international guidelines. For reference, there's probably 160 to 170,000 adults living in Ireland today with ADHD. The vast majority will be undiagnosed and unsupported in their ADHD. A recent Healthy Ireland survey from the Central Statistics Office indicated that 9% of adults in Ireland think they are ADHD. This is in addition to the children who are already identified. So actually, what services are available to those in supporting their ADHD? For children, there's the CAM service, but as awareness and societal acceptance of ADHD increases, so does the pressure on the HSE to deliver those services. So we see wait lists increasing for CAMs, primarily driven by families looking to get their children assessed for ADHD, and open cases in CAMs populated by ADHD service users. In January of 2021, in partnership with Minister Butler and the HSE and ADHD Ireland, the model of care for adults with ADHD was launched, but since then we've seen a tsunami of demand for both children and adult services struggle to keep up. It's estimated that now 50% of all new referrals into the child and adolescent mental health services is for people looking for ADHD assessment, treatment and support. ADHD Ireland has also seen that massive surge in demand for service over the past 3 years, and to be honest, we too struggle to keep up with that demand. This means that not every child and adult who has access to services for timely identification and ongoing support. While this comes as a significant personal burden to some, it is important to stress it's not true for all ADHD individuals. There is also a significant cost to Irish society, with an estimated socioeconomic cost for untreated adult ADHD at around $2 billion every year. So where does ADHD overlap with substance use? We're immensely grateful to our colleagues in Citywide and Trinity for developing their research on the interaction of neurodiversity with drug treatment services. And this research is showing that 51% of adults going through the services would screen for ADHD. This is also hugely over-indexed against the general population, but we see these figures reflected in other international surveys. We often say that the biggest challenge with ADHD is not the ADHD itself, but the stigma and low self-esteem that it brings. We carried out research with UCD and the HSE, which found that 20% of all adults with ADHD had attempted suicide, 50% had self-harmed, and 10% consider suicide as an option going forward. We also know that there's higher rates of anxiety and depression, and please bear in mind we're talking about 160 to 170,000 adults in Ireland today. Without knowledge of ADHD and access to the service can help, simply put, they self-medicate primarily with alcohol and cannabis.
But it doesn't need to be like that. We know that a combination of access to services and a societal shift towards a neuroaffirmative action approach can reduce the stigma and low self-esteem that can be true of many with ADHD. This can lead to which leads to self-medication and substance misuse. Neuroaffirmative action means that changing attitudes, prejudices, and unaccommodating environments across all aspects of society. This includes early childcare, schools, sports clubs, community groups, communal spaces and facilities, healthcare services, employment itself, third-level institutions, basically every aspect of society, holding in mind that ADHD children become ADHD adults who continue to need both support and acceptance. Adopting a neuroaffirmative approach towards ADHD will ensure that supports and accommodations are put in place so this population know that they are valued and productive members of Irish society. In looking to present solutions for you today, our big takeaway is that we know that the risk of substance use and misuse, suicide and mental health challenges are greater for the ADHD population. And indeed, there is a long list of other challenges that can exist for some but not all ADHD individuals. To medicate ADHD and substance use, along with other overlapping challenges, we need a whole government approach and strategy. In fact, we need everybody to come on board with this. However, while we are working on that, it's imperative that public services for adults and children alike are sufficiently funded and staffed by the Department of Health and the HSE and have a focus on ADHD care. In partnership with the HSE, ADHD Ireland remains fully committed to this agenda and would only be proper to acknowledge their ongoing support, which has helped deliver innovative programmes such as our UMAC programme, developed in partnership with UCD and the HSE, which we know makes a difference in the lives of ADHD adults today. To conclude, the ADHD community over-indexed for substance use. We know the challenges, we know the costs both on a personal and a societal basis. In keeping with ADHD Ireland's mission statement to improve the lives of all those connected to ADHD, we need to reframe ADHD and neurodivergence more generally. Thank you for your attention. We welcome any questions and comments you may have, and we look forward to engaging with you over the next couple of hours.
Guramagus, Mr. Kilbride and Dr. Morris. And now I'd like to invite Professor Comiskey to read her opening statement.
Thank you very much. Thank you for the opportunity to address the Oireachtas Joint Committee on Drug Use. I see my role here today as one providing you with the most up-to-date research, both Irish and internationally, on the topic of people who use drugs and are neurodiverse. A little bit of background. I'm Professor Catherine Comiskey. I'm based within the School of Nursing and Midwifery at Trinity College Dublin, and I hold a personal chair in healthcare modelling, global addiction and transformation. And my background is in biomathematics and healthcare modelling. I have been conducting research on substance use and related topics since the early 1990s with the emergence of the HIV/AIDS epidemic amongst people who use drugs. I'm also the former chair of the Scientific Committee of the European Monitoring Centre for Drugs and Drugs Addiction, and I'm current on that scientific committee at the moment, and I've also advised the United Nations. However, having said all that, what's most important to me is my work with the drug services since the 1990s. And I value most and was delighted to be invited by Citywide, who are in the audience today, to conduct research on people who use drugs and are neurodiverse. So what did we do? We looked at the prevalence of neurodiversity among people who use drugs according to the international literature. So this is not, just Catherine. This is the international literature. Then we looked at the prevalence within Ireland as identified within an online survey. And then we spoke about the experiences and needs of people providing this drug and alcohol services to people who use drugs. What did we find? We found, first of all, that there was no estimates of ASD at all in the literature. I think we found one amongst people who use drugs, so a serious lack of evidence there. But the overall estimate of the prevalence of ADHD amongst people who use drugs and alcohol was 21%. And when comparing rates amongst genders and substance use, the highest rate of ADHD overall was found amongst women using benzodiazepines. That had not been found before. So when we brought the literature together, we found that. And that was estimated at 40%. So women using benzodiazepines in treatment, 40%. The rates of ADHD were statistically significant, higher amongst males than females, among those males who used alcohol, who used cocaine, and who used cannabis. Similarly, for the first time, this study identified that the rates of ADHD were statistically significantly higher amongst females, more so than males, who used opiates. So we're talking about women who use benzodiazepines and opiates, and males using alcohol, cannabis, and cocaine. So in terms, that's the international literature. In terms of the Irish literature, we did a survey of 288 participants, and we found that the prevalence amongst those participants was 51%, and the prevalence of ASD was 37%. And again, something that we didn't know before in the literature, that the prevalence of ADHD at 64% was highest amongst the LGBTQI plus group. And the prevalence of ASD was 57% amongst that group. Cannabis was the illicit substance that most frequently used amongst the sample. There was no significant association between ADHD and people who have spent time in treatment and those who have not. And this may indicate that people experiencing ADHD are using substances and are not necessarily entering treatment services, although they may benefit from services given their substance use. From the qualitative work with service providers, it was found that most service providers did not have any formal education or training in neurodiversity. Managing the needs of people who attend these services has been learned on the job using a trial and error approach. Communicating with and managing people with neurodiverse conditions provided a major challenge for service provider staff, particularly when providing services for people with ASD. For some service users, it can take years to find an effective treatment programme based on their individual needs. Finally, the lack of a referral pathway through the Irish health system for adults who want to receive a formal diagnosis of ADHD or ASD was a barrier. Providing appropriate support for those with mental health and drug and alcohol problems was raised by almost all of the service providers as a major issue for service. Given time, I'll be brief on our recommendations. Our research recommended the following: a gender and sexuality-based drug of choice lens to ADHD awareness, modification to service processes and practice to ensure culturally informed communication, non-stigmatising strengths-based services, expanding existing training to include a whole service approach to immediate and long-term sustainable neurodiversity education, accessing expertise in developing integrated care pathways, and disseminating the Irish evidence and the international consensus statements to ensure human rights and access to evidence-based processes. So in a single sentence to summarise, I would say that we very much need training within substance use services, because people are coming in the door, they may not have a diagnosis, they're maybe having some behaviours, and services are dealing with those, and we need strengths-based. We have trauma-informed services. It's a buzzword. We need neurodiverse-informed services for people who use drugs. So thank you.
Thank you. Gurmagad, Professor Comiskey. And now I'd like to invite Mr. James to read his witness statement.
Thank you very much, ladies and gentlemen. I would like to thank you for the opportunity to appear before you today. My name is Philip James. I have close to 25 years' experience working as a mental health nurse in Ireland, working in both mental health and substance use services. For the past 2 years, I have been an assistant professor in mental health nursing in Trinity College. I'm also the current president of the International Nursing Society on Addiction. The main point I would like to convey in my opening statement is the need for comprehensive joined-up services when it comes to providing care for those who have substance use disorders, and particularly those who have an additional comorbid condition such as ADHD or autism. A study of adults with ADHD in England was carried out by Matheson in 2013, in which a participant, an adult with ADHD, stated, "Putting someone with ADHD through a bureaucracy is torture. It's like treating a diabetic in a bakery." I would like you to keep this statement in mind while I briefly discuss the development of services for those who have a substance use disorder and another mental health diagnosis. In December 1984, 41 years ago, a mental health policy was published in Ireland called Planning for the Future. Barry Desmond was Minister for Health at the time, and the report stated in section 13.42, the psychiatric services have an involvement in problems arising from both the illicit use of drugs and the improper use of prescribed drugs. The official classification of psychiatric disorders of the American Psychiatric Association classifies drug abuse and drug dependence as psychiatric disorders. If drug abuse escalates, psychiatrists will have the main responsibility for dealing with this problem. Well, since this policy was published, the drug problem has certainly escalated, but the fact that substance use disorders are mental health disorders has not changed. Both the American Psychiatric Association and the World Health Organization list substance use disorders as a category of psychiatric disorder. For example, Chapter 6 of the World Health Organization's ICD-11 diagnostic manual is reserved for mental, behavioural and neurodevelopmental disorders, where substance use disorders are listed alongside mood, anxiety and psychotic disorders. This makes sense as the treatments for substance use disorders are very similar and typically involve the combination of psychological, social and medical interventions. What has also changed is the inclusive approach of Planning for the Future in 1984. By the time the next mental health policy, A Vision for Change, was published in 2006, we were told that the major responsibility of care for people with addiction lies outside the mental health system, even though their substance use disorder is a mental health disorder. A study carried out in Cork City reported that 47% of those admitted to an acute mental health unit had a substance use disorder, either on its own or in combination with an additional psychiatric disorder. This is unsurprising research. Research generally estimates that at least 50% and possibly as high as 85% of those who have a substance use disorder meet the criteria for an additional mental health diagnosis. As Professor Comiskey's research outlined just a few moments ago, approximately 21% of those with a substance use disorder have ADHD. We have now arrived at a place where we have separate mental health, substance use and ADHD services. People with a substance use disorder often struggle to access mental health services, so much so in fact that the latest mental health strategy, Sharing the Vision, had to reverse recommendations made in the previous Vision for Change policy, as they were leading to the exclusion of those who have a substance use disorder from mental health services. This is just a sort of torture by bureaucracy the participant in Matheson's study warned us about. Living with a substance use disorder is difficult, and having an additional mental health disorder makes this more difficult. Likewise, treating substance use disorder is difficult, and additional mental health problems only makes it more difficult. But in the real world, this is how these problems present, and so it behoves services to address this reality. Regardless of the combination of mental health and substance use disorder, the best approach is when the disorders are treated concurrently. However, an international consensus statement about treating ADHD in combination with substance use disorder was published in 2018 and can guide this work. It is recommended within the current ADHD guidelines the HSE has published. The current configuration service means that this work is likely to involve multiple services. I would strongly encourage this committee to do everything in its power to ensure that, one, those with a substance use disorder are not excluded from mental health services. 2, support is given to substance use services to develop the skills to identify and support those with additional diagnoses such as ADHD and autism. And 3, mental health services are supported to provide interventions to those with concurrent substance use disorders. In summary, to return to the study mentioned earlier by Matheson, another adult with ADHD said, "I was very lucky to get a diagnosis, but the diagnosis really is not helpful without appropriate supports. It's disgraceful there just isn't a system. We need to ensure that those with substance use disorders can access appropriate treatment for any additional disorders they have, even though they have a substance use disorder." Thank you.
And thank you for your opening statements. Now I'm going to invite members to put their questions to the witnesses. Members will have 7 minutes for the question and answer combined, and once everyone has had an opportunity to engage, and time permitting, we'll have a second round. I'm the first speaker from the Fianna Fáil group. I'm acting as chair, I'm vice chair of this committee, and the chair will be joining us shortly. He sends his apologies, he's delayed at an earlier meeting. I want to thank you sincerely for your presence here today, your expert contribution to our work. It really does enhance our capacity to make strong recommendations that hopefully will lead to meaningful change. So I can't thank you enough for that initially. Your witness statements very eloquently articulated the nightmare, I suppose, that people are living with who are suffering from substance disorder and misuse disorder and mental disorders. And I heard very clearly, Mr. James, you know, one and the same. And how the ADHD community is overrepresented in substance misuse community. It's very stark, the figures and the picture that you paint. You've made some very strong recommendations, and our challenge, I suppose, as a committee is to take the report of the interim committee, which I presume you are all familiar with, the interim report from the last Oireachtas Drugs Use Committee, and make further recommendations. And my first question to you, and hopefully we'll get for a second round, my first question to you is, do you think it is essential for us to make the change that's required, very significant systemic change as a society and as a state in terms of our response to drug use and drug misuse? Do you think it is essential to achieve that, to have a repeal of Section 3 of the Misuse of Drugs Act? Is that something that is essential? And maybe Professor Comiskey, you could start, and then I'll come to Mr. Kilbride, Mr. Morris and Mr. James.
Thank you for your question. Yes, is the answer. I mean, people who use drugs, I mean, I've interviewed so many people who use drugs, and now through this study, people who use drugs and alcohol and experience neurodiversity. I mean, as Philip said there, the torture that people are going through. You know, I mean, I'm in admiration of these people every day that I'm doing this work, and that's why I do it. I was in a school this week with an 11-year-old doing some work with young children. And that future of that child, it was a Desh band, one school, and I was just thinking, oh my God, that child is going in the wrong direction. So, and the stigma and the challenges that families are facing. So absolutely, in terms of this particular work, I mean, the stigma is there. So we need for this to be mainstreamed in a sense to remove stigma, but also we have managed to bring in the discourse about, a trauma-informed services. We can do this. We can do this. We have done it before, neurodiverse informed services. The school I was in was a trauma-informed school. I'm sure they have training in neurodiversity as well, but that would be rare. We need this, and again, what came up in the sort of qualitative interviews was the stigma, was the torture that people are going through, and we all know that this is intergenerational. And as I say, interviewing an 11-year-old who's going around on a scooter with a mask over his face, robbing, is just shocking.
Can I ask you just, in that instance, so Section 3 deals with misuse of drugs and there's categorizations of drugs. Do you think it's essential that all illicit drugs, or what is your thinking, or have you thoughts on it yet?
We all, alcohol is a regulated substance. I mean, at this stage of my career, I would go for regulation, to be quite honest, because
Of all substances.
personally, yes.
Thank
I
you.
don't like saying that because it's controversial.
It's difficult to
but
say.
It is difficult to say, but at this stage of my career, who cares? I've seen the research over 20 odd years. I met a gentleman on my way in here and he said, I remember you, Catherine, from the 1990s. And I said, oh, thank you so much, because I was the first person to look at the actual number of people using heroin in Dublin. Everybody was saying we've 3,000. And Merchants Quay at the time were saying, oh, we've 10,000. Nobody believed them. The guards were saying we'd 6,000. We did the research. At the time, we'd 13,000. So I've been doing unpopular research for years. This is unpopular, but I just see it. And, intergenerationally, at this stage of my career, I'm going, this is not fair. It's not fair on families. We need to do something about it. So if what we're doing is not working, let's fix it.
Okay.
And you have an opportunity. Thank you.
Thank you, Professor Comiskey. Mr. James?
I'm earlier in my career than Catherine Comiskey, so I'm going to be a bit more careful with my words. One of the things I suppose to look at is, Catherine mentioned stigma. Probably the most stigmatised drug out there is heroin, and probably the least stigmatised drug is alcohol. But actually the people who take the longest to come to treatment and the lowest percentage turning up in treatment are people with alcohol use disorders. So I think, I'm not sure the two are definitely connected.
What does that tell us?
So I don't have a very strong opinion one way or the other, but I think that the challenge that where stigma does come in is when people with substance use disorders try to access other services. They're very welcomed into substance use services. We try and get them in very, very quickly. But when they go to mental health services and look for additional treatment, they're often pushed back and there is a stigma there. And that's the main stigma I would like to highlight.
Great. Cormagus. Mr. Kilbride?
You've used a couple of words, and it's been used already, nightmare torture. But why is it nightmare and torture for people with ADHD and other neurodiverse conditions? It's because they simply haven't been recognised. And people didn't get any support. So forgive me, but I'm not saying the same age as Catherine, so Catherine's younger. But when you went
We're
through
not
school,
ageist here, we don't discriminate.
nobody was getting any support. It's only in the last 4 or 5 years that we're now seeing, more widespread societal acceptance around ADHD. But, forgive me, we mentioned the figures around suicide. Yeah. But, there's also higher rates of marital breakdown, higher rates of unemployment. The prison population has a problem, a challenge there. We know it's going epidemic across the entire society. And stigma, as we mentioned in our presentation, it's not the ADHD, it's the way society treats people with ADHD. If we can remove that stigma around the condition, you will help to sort out ADHD. In question, back to section 3, more of a personal opinion, I worked in the area of drug or alcohol a number of years ago. At that stage, the economic cost or socioeconomic cost of alcohol misuse was about 6 billion per annum. So we were only bringing in 3 billion in terms of cost. So purely on a cost basis, let's look at it a different way of doing it. But in terms of just, looking at ADHD, if we can change the way society reacts to ADHD as a condition, well, then we can mitigate these issues around substance use.
Gormagus. I can see I'm out of time, Ms. Morris. I want to be fair, and the chair is here, so can we leave Ms. Morris answer? Maybe you and I could swap over. And thank you, and I apologise. I am going to have to leave to do something else, but I will be back. Gormagus.
I obviously agree with my colleague Ken from ADHD Ireland, and I suppose there's a multitude of variables that are interacting here, and I think for ourselves in ADHD Ireland, what we want to emphasise today is that stigma piece, but also a preventative piece. There are so many supports that can be put in place from very early on in a young ADHD person's life that can prevent that self-medication component or prevent mental health concerns, which can often, as our colleague at the table also stated, can co-occur with substance misuse and abuse of substances. I know if, as I am were here, they would be talking about that same chance programme that they've been rolling out over the last few years. We know that substance misuse is higher in the autistic population, even higher in the ADHD population. And I suppose from an ADHD Ireland perspective, we'd also like a same chance for ADHDers too. The same barriers to societal access are there for the ADHD population as they are with other neurodivergences. Our systems that we have set up over the years are set up with the majority in mind, and it's only recently that we've become more cognizant of the fact that we are excluding members of our society which leads to low self-esteem, which leads to mental health concerns, which leads to, I suppose, a turning to criminality, a turning to, a feeling that you've been rejected by society. And then, evidently, according to the research, a turning to substance misuse and drug and alcohol dependency. So I think the intervention needs to start at a very early age, starting with a societal change in opinion, but also a changing of our service structure and how we conceptualise ADHD right from the very beginning, so that there's protective factors in place for the ADHD population and we're reducing the likelihood of substance misuse. With regards to Section 3, I don't have a particularly strong opinion. I think that you probably wouldn't need to be looking at it if we had put those supports in place already and the ADHD population weren't being so marginalised.
Thank you, Ms. Morris. Deputy Murky, you're next.
My God, here, look, I was the false roof Giller. Right, look, in fairness, this is wildly scary and interesting all at the same time. Professor Comiskey, just to get these figures right in my head, right? And first of all, when we're talking about the overall estimate of the prevalence of ADHD was 21%. That's on the basis of international evidence. Now, see that cohort, are they people not just who take drugs, they are people who would have, for the want of a better term, a substance abuse disorder? Yes.
Sorry. These were people who were either in treatment or had problems with substance use, not necessarily a fully diagnosed substance, but yes,
I get it. But
your average cannabis user, no.
Exactly. And I'm assuming the same goes for the people that carried out the online.
The survey, yes, and that was 51%.
And that's 51%,
yes,
right?
Yes.
And I assume there will be some attempts to follow up on that, because that's a phenomenal number. And like here, I know I'm going to ask you without the evidence. Like, if you were taking a bet in relation to what sort of prevalence we're talking about, are we talking 21% or 51%? Because that's a huge difference.
Yes, it is. Well, for a start, 21% is high in comparison to the general population. So when we went through all of the papers, the international papers, it was up as far as maybe 60-odd% in some maybe prison settings. So the 21% was quite sort of modest overall.
So it's a conservative number?
Oh, very much so.
Right.
Oh, yes, yeah. Depending upon the setting, it could go much higher.
No, and on some level, we probably need something comprehensive to be done in relation to actually, I would be absolutely afraid of my life in relation to what the number would be. Well, then that just begs the question straight away. Look, we know the whole issue in relation to, particularly if we're talking about neurodivergence and we talk about autism, or we talk about ADHD, and then the comorbidities and the issue in relation to getting supports, etc. Look, that is not an issue that has widely improved in recent years. But if we're talking very specifically in relation to those who obviously have a predilection to have to become an addict, I suppose it's what preventative measures, what supports we can actually deliver early enough, because then afterwards, you've already stated, then it's having a service that can at least address the fact that there's a considerable cohort of people who are going to have the dual diagnosis of addiction, and be it ADHD and autism or whatever.
Yeah, so in terms of the continuum, if you start with prevention, or you start early, and that's why I really thought about the recommendations and discussed them with Citywide and ADHD Ireland and with my colleagues. What is practical? And I was thinking, well, we do have trauma informed, and everybody understands that. So if we can bring in that neurodiverse informed, then when I went to school, the bold child was in the corner or outside the door. And that child thought they were stupid. They weren't stupid, that's just, we were not informed. So we need to be bringing in across the continuum, but one place to start would be in that neurodiverse informed services, and start bringing that language in and bringing it in where it's needed in the schools, and in this particular case relevant to your committee, into the drug services. And then obviously going from prevention, you've got your universal prevention, you've got your different, targeted prevention for children who actually have maybe a diagnosis or are waiting for a diagnosis. So, we can follow the whole system and add on to the system that's already there.
Oh, look, and if we had a perfect system, you know, supports kick in straight
Yes.
away. It's almost, you can screen before you're ever assessed with all the issues that exist in relation to assessment. And there's probably an element when you're dealing with people who believe or have that they have ADHD or in fairness have a diagnosis. It is the fact that obviously they have to be pre-warned that they are going to have a greater likelihood of developing an addiction.
Well, I don't know about that. No, not necessarily. I wouldn't think so. I mean, that's why it's prevention. It's called prevention, to prevent that happening, so that children understand themselves, that they don't feel that, you know, they're frustrated, that they get the right treatment, that they're in an environment that is neurodiverse informed, so that that child's self-esteem and self-worth and whatnot is, you know.
I get it, and it's that question, is it a stigma or is it also, you know,
we need more training, and you know, and the training will reduce the stigma.
And a greater
Yeah,
level
and
of
it's
research.
something that can happen. I'm very practical. You know, we can talk about changing the HSE, doing this. But this can be done. This is practical, and it would be a lovely positive outcome if it were done.
No, because I've seen some simplistic or simpler, I suppose, interventions, and you know, my wife works for the Changing Lives Initiative, and I'm not trying to plug them, but it was the idea that it was kids that screened with ADHD, and then it was working with, you know, the family, the child, and whatever, to create better circumstances in home, school, etc.
Yes.
And you know what I mean? And that allowed for, what would you call it, de-escalation of, you know,
the whole
meltdowns.
school approach. The whole school approach.
Exactly.
May I just add in one thing about the training? Citywide have actually started this and put their money where their mouth is, and we are actually developing a massive open online course with, it's a free open online course on neurodiversity. The background and ADHD Ireland are supporting this as well. It's a small first step, but we are, Citywide and ADHD Ireland are putting their money into this, and Trinity are developing, myself and Philip and colleagues, a massive open online course. It's called a MOOC, and anybody in the world can access that, and we'll have the evidence, and we'll have it's a very first step, because we believe in answering the problem. Do something.
Oh, that's good.
Yeah, I was just going to say, from a prevention point of view, it is recognised that children with ADHD are at a greater risk of developing a substance use problem. Yeah. We do know that, you know, there's recommendations that they should be screened, people in CAM services, not just with ADHD, because they're also at increased risk. And so really what we need to do is have a better screening in CAMs for substance use problems to try and catch them early. But if people are not getting diagnosed with ADHD till they're in their adulthood, well, then we're missing the opportunity, and there's a good chance, because ADHD, and Dr. Morris might want to correct me on this, my understanding is it has to present before the age of 12, which means that in vast majority of cases, the ADHD is there before the substance use starts. But if we treat those young people and identify them early, we actually can prevent it hopefully progressing into a more complicated picture of substance use.
Again, if we had those therapies and assessment means within schools or early learning. Oh, sorry, I must have missed that, John.
Next contributor is Senator Costello, Oireachtas.
I just came in late, apologies. It's kind of sad to hear about children with ADHD and the statistics with drug and substance abuse, and I think maybe if society was a little bit kinder and accepting of differences in personalities, I think we wouldn't have half the problems that we have. I understand, like with children with ADHD, they've been given out to buy thousands of times more than the average child by the time they're 6 years of age. They get excluded from birthday parties. They get excluded from play dates. They don't feel they belong in clubs that they're in. So immediately they're experiencing isolation, social isolation, and that can be even by family members and everything. So it's quite understandable for validation and for self-esteem how this can happen. I wouldn't like to preempt that a child with ADHD, or I wouldn't like to label them that they're going to become a drug user. I think that there definitely needs to be a focus on extracting their strengths from them, because I actually, and I've personal knowledge of ADHD and the process it takes to diagnose it, and how sometimes trauma can mask as ADHD qualities, and it can take quite a long time, and also finding the right therapists. I think that a focus on talk therapists is huge. Having a child with ADHD, to find a person who they can look at nearly as a role model and who they feel accepted by is a huge step in, and kind of who they can be influenced by. It's who they're influenced by. I think the school system certainly needs training and how to deal with children with ADHD as well. And I think the people who I know who have ADHD have kind of superpowers. They're very focused, very strong when they take an interest in something. It's this emotional, and I think there needs to be a piece on the emotional maturity side of children with ADHD and stuff like that. There's one thing, and I've come back to it a few times in this committee, around, and it affects neurodivergent children when they get, there's domiciliary care payments being made up to the age of 16, and when they get to 16 they're transferred over to a disability if they're accepted for it. Do you think that that's an issue? Do you come across children who are kind of, the money's in their hands, they think they're old enough to know how to manage it? Do you think that can come up as a stumbling block, that they've access to more money, and that means people who would prey on somebody slightly vulnerable might see it as making them more accessible for drugs? Is that something that you think?
Just obviously I'll come to Sonia side, but it is well known that children with ADHD have what's called an emotional maturity delay of about 25%. So if you're dealing with a 16-year-old, you have an emotional maturity of a 12-year-old. Yeah. With impulsivity, when they get into the wrong social group, they can be easily manipulated. Will you be the one go down and do the shoplifting, you throw the picture, whatever happens to be, because of the condition that goes with it. Other figure that, I don't know if you're listening to any of the talks that I've been doing, but one of the figures I use when I'm out doing talks is that it's estimated that a child with ADHD will receive 20,000 pieces of negative stimulus by the age of 12. And this is what causes that low self-esteem. But then there's also what's called RSD, so I don't know.
The rejection.
Rejection sensitive disorder, in terms of emotional dysregulation.
Yeah.
So you have emotional maturity delay and emotional dysregulation.
Yeah.
You get those two together at the same time.
And that's trouble. And also just education around the medication with ADHD, as parents who may be facing into a diagnosis that their children have an ADHD. Sometimes parents can feel that by putting their children on the medication for ADHD, they're failing them, they're taking an easy way out. I think there needs to be a whole education piece around that. This is a medication that can really let the child reach its full potential, and I just don't feel that message is out there strong enough for new parents coming along. And sometimes I think an issue can be, and I don't know if you would agree with me on this, if a parent waits too long to get their child onto the ADHD medication, then it's a big deal for the child, and they may refuse medication, and it can be more of a struggle of getting them into the habit of it. Whereas if you do start them maybe younger, rather than delaying and feeling as a failure as a parent, or feeling you're taking an easy way out. Like, is that something that you're coming across? Because I certainly know how that feels.
I mean, it can be true, obviously. Not true for everybody.
Yeah.
It's very much a personal decision on a family about whether or not medication is the right route to go with the child, and then obviously for an adult, an independent choice. All you can do is give the information about what the benefits could be. And we also need to recognise that ADHD medication is not effective for every ADHD individual as well. So there needs to be, I suppose, less of an over-reliance on medication is the answer too. There needs to be other supports that are put in place alongside of it. It's great that there is medication available. I mean, for an adult population, it's only in the last few years in Ireland that we have public services available to adult ADHDers to access in order to avail of that. And we know that there are vast, populations within Ireland that still don't have access to those adult services. So even from a medication point of view, they don't have that. I really agreed with almost everything that you said. And with Ken, with his comments about the amount of negative comments that are made to an ADHD child, and I agree with my colleague here, Professor Comiskey, that there needs to be a neurodivergence-informed approach to service delivery across all aspects of society in order to prevent that from happening, so that our kids are protected against low self-esteem as they grow and they develop. Accessing therapy is all well and good, but if those therapies aren't adapted for a neurodivergent community, then there are barriers to accessing those therapies too. So while there needs to be trauma-informed care, there are also, I'm in complete agreement, needs to be neurodivergence-informed care as well, because otherwise the efficacy or the evidence base for improvement just isn't present.
Yeah, and I think medication on its own is not the right way. That there will be talk therapy required throughout, and that's so important as well.
Thank you, Senator. Thank you. We're 7 minutes up. Our next contributor is Deputy Anne Graves.
Thanks very much for coming in, and I really enjoyed reading through the presentations even before you gave them. There's a huge amount of information in it, and in recognition of the fact that neither ADHD or neurodiversity was included in previous strategies, I think it's important that it is this time. And for yourselves from ADHD, like if it was a case that we were to include ADHD in the drug strategy, what would you feel would be the important actions to have included, and who would you see as being the lead people responsible for making sure that they'd be carried out?
I suppose what's important to emphasise is that it's not just ADHD, it's neurodivergence more generally. We have stark figures about ADHD, but I think to single out ADHD in a policy is probably short-sighted.
Well, I'm thinking both, but I'm asking
the key changes, I suppose, is access to services, much like has been commented on across the table. Starting at a very young age, so obviously our wait lists for CAMHS across the country are very variable, but overall, I suppose when you look at the stats who are on the wait list for CAMHS, it's very rarely kids waiting on mental health intervention. It's the ADHD query kids that are waiting for assessment and identification. We have a real challenge with adult service provision at the moment in the country. The adult model of care hasn't gotten up and running across counties. The teams that are establishing are really struggling with the demand for services. So much like, I suppose, every issue that's on the table at the moment, it's resourcing. And it's a cross-service approach, I think, that needs to happen. We do need more ADHD acceptance and awareness programs integrated into schools, given the fact that, Ken will let you know the prevalence, but there's at least one ADHD child in every classroom across this country. And the fact that schools do not have access to ADHD informed teaching methods and accommodations to be made within those settings means that those children are already set up to have barriers with accessing the educational curriculum. And as pointed out by other members here today, the other aspects of community, like the social engagement that comes from being in school, or the birthday parties and all those sorts of stuff. So it needs to start there. But also, like, the stigma about accessing services in the first place. There are plenty of adults that present as ADHD who are unwilling to go to their GP to ask the question, is this ADHD? Because of a stigma that's associated with what that might mean. So while it's important to focus on service delivery, specifically for ADHD, we also need to be focusing on how to making it more acceptable to be identified as ADHD in the first place, to act as a preventative measure for drug misuse and substance misuse and self-medication.
Yeah, I think, like, I've a lot of experience of parents that realise as an adult when they get their child assessed that they have also ADHD, but they only realise when they get their child assessed, well, they're exactly like me and they've gone through the same thing. So it is, I suppose, Catherine, and it's in follow-up to that, around the barriers to people accessing service, but I'm greatly interested in the MOOC, is that what you called it, the online thing? So just if you could tell us a bit more about that, because it sounds really interesting. Who would it be geared towards? How, I know you said it on an online but is it a case that, and we've spoken about children not getting access to diagnosis, will it be available for undiagnosed children or people where they feel that there's a problem because they present with? Yeah.
Do you mind if, before I answer that question, I go back to your previous question?
Yeah,
so I was very much involved in the last drug strategy, so I'm aware of the action plan and who's responsible and who's around the table. Yeah. And I will say that I'm not at the table this time, and that's a different argument.
You and many others.
But because I was at the table previously, I know how it works. Okay. So I would suggest that this is a whole government approach, that within each, say, the Department of Education, that there should be something related to neurodiversity through maybe the SPHE programme, to the Department of Justice, you know, through the prison service. They are all, or they were at the past, I don't know who's at the table now, but I just know who isn't. They all had actions. So I would get a sentence or a half a sentence into those actions, because the actions are accountable and they're measured. And if it's not in the strategy, it's not accountable, it's not measured, and it won't happen. So that's just your previous question. In terms of the MOOCs are fabulous. Yeah. We've done one before. This is on, as I say, informing people about learning from ADHD Ireland, you know, from their materials and from the literature. It goes through what is, you know, explaining the background, and then how to inform a service, what's best practice within a service, strengths-based, you know, pulling out on the strengths. So it's hosted on a platform, and anybody in the world, anywhere, can access that. So it's a very nice first step, and they're not expensive to develop. It's about 30,000 to develop one of these. Okay. The one we developed previously was on addiction nursing, and we've had about, 4,500 people all over the world have actually access to that. So once it's there, it's sustainable. So you're not relying upon, you know, oh, that trainer has left the service, or that teacher has left the school. So if we could build upon that basic module that we're doing at the moment with ADHD Ireland and Citywide, we could develop one for schools, because I know the schools are overrun with, you know, we have to do this, we have to do that. I'm doing a big evaluation of drug and alcohol use in schools. But this is something that a teacher could do, you know. It's literally 6 hours over a period of 3 weeks. So it's something that can be built on. It's not expensive, and it's a very practical. So that's you know, an example of what can be done. Okay. But definitely you need to get something in the actions. Okay. You know, actions speak louder than words.
Okay, yeah, thanks for that. And just to note, I actually met with the Minister yesterday in terms of the strategy and the development, because one of the major concerns that I have is lack of consultation and involvement by stakeholders, and it's been raised at you know, this committee on numerous occasions, and every group that comes in hasn't been consulted. But she has committed here at the committee, and then when I spoke to her yesterday, to wide-ranging consultation with all stakeholders. And I said to her, what about the international perspective? So they're actually working on their consultation programme at the moment, and she hopes to have it next week. She did say alcohol would be included in the drug strategy as well. So, you know, I think when the opportunity arises, we will get a draft, and, you know, we should be looking at adding stuff to it as well. Can I have, just bear one?
I'm sorry, I have to
bring I have to leave for about 15 minutes, so I'll come back then.
Yeah, absolutely. We'll have a second round. Thank you, Deputy. Yeah. Senator. Go.
Thanks to all the witnesses for coming in. And just to reiterate what Deputy Graves said, we have advocated for those stakeholders who are not at the table to get back at the table, because they've come up a couple of times at this committee, and we've all been pretty unanimous on that. You've come in a good week, I think, as well. The mental health bill is going through the Seanad at the moment, and there have been a good few discussions and debates around dual diagnosis. So I'd just be interested in your thoughts, any of your thoughts on how we are supporting or otherwise people who are presenting with both an addiction and a mental health issue, or ADHD, or anything that goes along with, as we know, that's how people end up in addiction. A lot of the time they're self-medicating from a young age. So just your thoughts on our legislation and our gaps.
Yeah, I mean, I think we've very good policies in Ireland. I mean, our policies really make sense when you read them, whether it be about ADHD, but the general kind of consensus is that if you have two, say, a substance use problem and a mental health problem, you treat both concurrently. There was a tendency, and this is what got changed in the new mental health strategy, for basically one disorder to be kind of treated first, usually the substance use disorder, and we won't treat the mental health. That's the theory. And that's great. It's in black and white in our policy. The big concern is on the ground. That can vary from area to area. And there will be services where one psychiatric team will be very open to treating somebody who has concurrent substance use problems, and another team that may not be. And that's a big barrier for people. It's basically a geographical lottery, depending on your catchment area and where you live. So I would love to see those kind of things I suppose, become the norm, that policy is done. The legislation, I suppose, is a different matter. I suppose I'm not an expert on the mental health legislation, but I suppose it is, I suppose, more about treating people, I suppose, against their will. And there isn't a tradition in Ireland of treating people for substance use against their will. But the reality is you will have a lot of people who will have for example, a psychosis and a cannabis problem. And they will be treated for the psychosis against their will. But we want to make sure that the substance use is not used as a reason to not have somebody access mental health treatment.
Yeah, so that's kind of come up a good bit this week, just in relation to, like, if there is a legislative gap, or not a gap, but if it's something isn't proactively described in legislation, but the policy is quite strong. But are you saying that the implementation of the policies is ad hoc, or
it varies? No more than the ADHD policy is very, very good in principle, but trying to get, we have a problem in this country of putting the resources into mental health services that's needed. We are below kind of the average around Europe and around developed countries in terms of the amount of investment we put into mental health services. So they lag behind. We have the great intentions, but the implementation it needs more resources. We have a shortage of mental health nurses, we have a shortage of psychiatrists and psychologists and speech and language therapists and OTs and everybody. So we need more investment and a greater access to service.
Catherine, can I ask you about training with substance use? You were talking about neurodiverse infirm services.
Yes.
Can you expand on that a little bit? Would you see that being rolled out or being supported through, like, CPD for people who are already working for addiction services, or how would you see that rolled out?
Well, that's one way forward. This MOOC that we're developing is developed particularly for people who are working in the drug and alcohol services. So it's a very, very basic training about what is neurodiversity, what is ADHD, what is autism spectrum disorder, and how then do people manage that in a treatment environment. For example, within one of our studies, in this particular study we did here, we had somebody who came into like, they might not be able to make a phone call, or would find, if there's a lot of noise going on, to make a phone call or to keep an appointment, and then you're getting missed appointments. So another person said they found it really difficult to go to group treatment. So, group therapy. So that wasn't appropriate. So, but if the service maybe had been more neurodiverse informed, they wouldn't have offered that person group therapy, or, you must be here at 3, or, or you're failing on your part, therefore you're not going to get treatment. So it's we can do little things that will make a big difference. That's just my basic understanding, but perhaps my colleagues here might be able to say more.
One of the things, just in reference to Catherine was talking about there, I just remember we started doing adult support groups a number of years ago. And we were just talking about, using the phone. And half of them went, I don't like using the phone. And people were going, I'm not taking up as employment, I'm not going into college, whatever else, I don't like using the phone. There's things like that that are happening on a regular basis. But, we talked about the model of care there, and it's only, introduction since 2021. And the HSE, frankly, they know they've struggled in terms of getting those clinics up and running around the country. They have 4 or 5 clinics, all 50% staffed, and they're all lacking key staff. So there is a big job to be done there in terms of providing those services. But we did have that discussion over in Buswells about, that was the question you were asking about, how do you treat or work with someone with ADHD? And I know that just Philip had one answer, and Sonia had a slightly different, not different answer, but a different perspective on it.
What's your perspective, Sonia?
That's why I show you on the bus.
We were having a very lovely discussion before coming over, very respectful, about, I suppose, joint up service provision and the challenges with identifying accurately ADHD when there is a co-occurring substance misuse problem that's ongoing at the same time, because like if you take, for example, cannabis usage, that is obviously going to have an impact on your ability to sustain attention. So when I work in the CAMS, I'm one of the clinical psychologists in that service, and I would do a significant number of ADHD assessments weekly. And we do have young people who would come in who would be recreational drug users. And you can still tease apart ADHD from the impacts of drug use. And some of the challenges that we have, though, is if somebody is dependent on a drug or would be a heavy user of certain substances, then it becomes very hard to judge what is ADHD and what is an impact of that drug use. So it was, I agree with my colleague that there needs to be joint up service provision, and there needs to not be barriers to accessing services. But I suppose there still needs to be recognition of the fact that sometimes a focus on one challenge for an individual might need to be prioritised over identification in some instances, but it means accurate identification. Because I have seen the aftermath of an incorrect identification and the consequences that that would have for an individual as well.
Okay, thank you.
Senator Rowan.
Thank you, Chair, and thanks everyone for your presentations. As a medicated ADHD person, I am absolutely delighted to hear I have the emotional maturity of a 35-year-old instead of a 41-year-old. I feel a bit like I'm winning. But I suppose my diagnosis with ADHD completely transformed my life in many ways. It came with a huge grieving process that I didn't expect. Remapping my life, I suppose, through that new lens and understanding myself in a completely different way, and not realising the shame that existed there, not realising that I probably would have parented differently if I understood the neurodiversity in the household. There were so many layers that I had to kind of think and kind of sit into as with this new kind of understanding. But then it also made me think about all my years of working in the drug services, and thankfully I always had, I suppose, a natural ability to treat people how they wanted to be treated regardless of a diagnosis, so how they wanted to engage in a service, whether they wanted to do group work or not do group work. You know, I was always very accommodating that, because programmes should be tailored anyway, because regardless of any sort of other diagnosis, people engage differently and we shouldn't be trying to fit people in. And I think my experience of school would be an example of that. Like, I mean, I'm working in the area and obsessed with drugs policy and service provision since I'm a child. And if they had just let me focus on that, I wouldn't have probably been thrown out of school by the time I was 13, because they were trying to make me do all these other things that I had absolutely no interest in, but was very capable. But then thought I was the bold child, of this child, of that child, when actually I just didn't care for what they were talking about, and wanted to do other things. And I think about all the people that end up thrown out of services, out of spaces and out of schools because they're seen as difficult, rather than seeing that the institution that they're trying to engage with is actually just way too rigid. And I suppose then do we need to look at how services are run, because in Ireland right now, like say if you want to get into a residential treatment, you may need to attend a group piece for 6 weeks to get into treatment. And there's no inflexibility, and there's a complete discrimination happening there. And the thing is that many people won't arrive with a diagnosis because we come from areas that are extremely under-resourced, underserved. Families don't have money to be paying for private, so you can't then just base your service on even somebody showing that they have. You have to just be able to move and be flexible and find other ways. So I think the neurodiversity training is extremely important in that, but I worry that if a service is saying it's trauma informed and it doesn't already then cater to neurodiverse people, because if you're that trauma informed, there's a natural kind of a way in which you engage with people. Do you know what I mean? So if you just treat everybody trauma informed, it probably would have been better for neurodiverse people in the first place. But what I'm wondering is, how do we go about, beyond the training, how does this committee go about, I suppose, creating a policy, and a policy that's implementable, so that people are not being pushed out of addiction treatment or because they don't want to engage in groups? That is one that stands out to me, because I've had to advocate for people not to be put into group sessions. So do you think that that's just a culture that has to change at a service provision level, or do you think that there's a policy at this level that can make sure that that's what happens on a cultural level?
I think it would be useful to build into policy that there'd be a necessity for stakeholder engagement during the revision of how services are provided, people's experience of accessing a service and engaging with it. So that change that is informed by the neurodiversion community gets implemented into practice as well. I think, like what has been mentioned here, that we are really good at developing policies as a country. Implementation is sometimes lacking, but also I think, reevaluation of policy with the people who it matters to most can often be lacking as well. I've heard lots of examples of some of the barriers that can be put in place to accessing a service, such as rigidity around the type of format in which therapy is delivered. All of those executive functioning challenges that we know are inherent to an ADHD community, like time management, organisational skills, completing homework in between sessions for therapy and all those sorts of things. And I agree with yourself, there needs to be more flexibility. How that gets translated into policy is very challenging, but one of the things that absolutely springs to my mind is that the neurodivergent community are becoming excellent advocates for themselves because of that reduced stigma. So allowing them to have a voice in service development is probably, in my mind, the most important thing to make sure is prioritised.
Because something that kind of comes up as a concern for me as well is people, because I still act, for some reason, I'm not a drugs worker, but I seem to still act as one in certain communities. So when I'm kind of helping people with referrals or trying to signpost them in particular directions, I find sometimes that somebody who has an ADHD diagnosis, and sometimes they end up in certain types of residentials that see them looking to go on ADHD medication as drug seeking. So there's a real stigma being created by services. In the prisons, the prison doctors wouldn't give ADHD medication. They're only at the beginning to change that now because people were seen as drug seeking. And then any sort of behaviour, whether it's impulse control, whether it's ever, if they were getting into fights, if they were getting frustrated, they were then being punished for something that they were seeking help for. Do you know what I mean? And then the criminality thing then, comes on top of them because they're kind of, they're not getting what they need. So I'm wondering, how do we go about that? Because there's a lot of people that work in an abstinence space that even when it comes to psychiatric meds or mental health meds, come with this message that actually that's some sort of drug seeking and that's a threat to your recovery. I'm just wondering what the thoughts are on that.
It goes back to the policies that are out there, the evidence-based practice, which is you need to treat both disorders together. And unfortunately, if you work in a drug service, there is a possibility that your service just sees people through a drugs lens. But what we're kind of saying is there needs to be more lenses than that. People are a lot more complicated than that in reality. So if you can't work in substance use services effectively if you don't understand people, kind of mental health on a broader sense. And sometimes people need psychiatric medications. And I think that, a lot of those philosophies that are very rigidly stuck to in services probably are not conducive to the kind of policies we already have around recovery approached and trauma informed. So I think those policies need to be looked at, where they're very rigid and if they exclude people. Yeah,
because I have friends who have thought that they've actually broken their recovery because they've accepted certain medication for certain conditions. And I just think that type of framework is absolutely appalling and just adds to more shame in people.
Everyone's very eager to get in, so I'm going to stop that there for a moment. Senator, Deputy Marisha,
and look, I want to really warmly welcome the session we're having today, and thank you, witnesses, for attending and for the detailed submissions here as well. I think the figures are very stark in terms of the incidence of drug users who have ADHD, and I think others touched on it in terms of. I was very struck by another session we had in terms of the prison system and the very high number, I think it was somewhere close to 80% of those entering prison at the moment who have substance abuse. And then, of course, there's this other layer of being neurodiverse as well, and how ill-equipped our prison system is, and Senator Rowan touched on a lot of the how badly handled then people are because of that lack of screening for neurodiversity. And of course, I think the big message that has to come out from today is that obviously, if we get the right diagnosis and supports in place for children at an early age, then we can prevent that self-medication, later on in life. But I suppose I just want to ask, so there's two things I kind of want to ask today. Firstly, about the concurrent treatment, and I hear very much, Professor James, what you're saying about the theory being there and then the breakdown and, the inconsistency of practice. So, why has that emerged, or how has that been allowed to continue? Because if there's a policy in place, it's up to somebody to execute it. I just had a quick look there. I don't know if the Mental Health Commission has conducted research in this space, in terms of, obviously they're the main advisory body to government in terms of, the implementation of mental health policy. So I'd like to just hear a bit more about why we have that geographical lottery, and where is the failure been?
The short answer is I don't know. Okay. I think it's kind of stuff at a local level. The policy is black and white that, if using substances shouldn't be a reason for excluding people from mental health services. The way the old policy, the one from the 2006 was worded, it kind of suggested they could be excluded. But I suppose there's been a lag in terms of that changing in certain regions. And I know, both from when I worked clinically up until 2 years ago in substance use services for adolescents, and when you talking to colleagues now doing research and even just casually, that still exists. There are certain kind of teams that are very slow to take young people if they have a substance use history. And, my wife's a mental health nurse. I know it happens in adult psychiatry as well. And all the research backs that up. All the anecdotal evidence, all the evidence from talking to service users is it's very difficult for them, if they have a substance use problem, to access mental health services if they need them. Not in every area, but in many areas. The policy is there. I'm not sure, because the Mental Health Commission looks at what happens in services. The problem is if people can't get in, they're never seen by the Mental Health Commission. They never come onto that radar. Sure,
that's and that's a fair point. I think we might just check whether the Mental Health Commission has said anything in this space, and if not, maybe as a committee write to them to suggest that. I think guidance from them would be important. I suppose the other thing is, obviously, Ireland's, is not on its own in this. So are there other countries who are well ahead of us in this space, who are doing things particularly well, particularly in terms of, that process modification piece, in looking at substance abuse through, a broader lens than just the substance abuse itself?
I might just say something on that. I don't, ADHD Ireland might be able to give more detail, but we looked at what are known as the International Consensus Statement on screening, diagnosis and treatments of substance use disorder patients with comorbid ADHD. And it clearly states here under treatment, consider adequate medical treatment for both ADHD and SUD. And then it says, integrate the ADHD and other psychiatric comorbidity treatment with SUD treatment, substance use treatment, as soon as possible. So this is saying you don't have to wait until somebody's not using substances to treat the ADHD. But I suppose, there's only a certain amount of evidence, but based on the international evidence at the moment, as good as it is or isn't, that is saying that they should both be treated concurrently. But I think maybe there's a nervousness about that, as Senator Ruan mentioned out. I'm not in the medical aspect, so I don't know where that's coming from, but it's clearly in the international consensus documents that they should be treated based on the evidence we have at the moment.
Sure. Yes, and then,
And can I just say that's made all the easier when we know that somebody is ADHD, accessing the service. So, that co-treatment piece, if you are aware that somebody's ADHD and you think that medication would be helpful, then, both in tandem works. The challenges are if you don't have that identification piece in early childhood and you don't have that confirmed identification even in early adulthood, then that process of accurate identification becomes all the more concerning, because then that limits, I suppose, psychiatrists' confidence in accurately prescribing ADHD medication.
Just to say on the same point, to reiterate what Philip was saying, to take the exact quote that we're saying, if you can't get into the mental health services, you're not appearing as a statistic. And just to say, and I mentioned in our opening remarks, is that, the wait lists are generally populated, particularly in the children's service, for people waiting for ADHD assessment. then try and get into the adult services. You know, we know certain ones around the country put out letters saying, our wait list is 4 years long, we'll get back to you sometime.
Yeah, it's no list at all.
Yeah, to be honest.
It is particularly cruel if somebody is a couple of years on an ADHD waiting list to get assessed, and in that time develops a substance use problem, to then be told, well, you can't get assessed because you've got a substance use problem. Well, they didn't when they went on your list. And that's kind of frustrating. I suppose you asked about services that are available. The consensus guidelines that Catherine mentioned do mention about kind of that knotty problem of dealing with diagnosis of ADHD when someone's already using substances. And there is international guidance there. It is in the ADHD framework that the HSE has published, so it's already part of policy. So that is there to guide people. And you asked about services. There's a particular service I like in Australia called Origin. I think it's Melbourne, and they take this very broad view of kind of mental health, where lots of services for young people, I think they worked up to about the age of 25, are available in one building. So people who turn up, say, looking for help with a mood problem, and they discover, oh, you're smoking cannabis as well, they're just down the hall. Yeah. I'm currently doing research, and I was talking to somebody who was originally working in an adolescent substance use service, but they were based in a building with social workers, with CAMS, with various other services, and they could nip across and have a chat with people. Yeah. They've been taken out of that, and they've been siloed, and that means that those kind of connections and informal things don't happen. So the more we silo services, the more access gets difficult.
Yeah, absolutely. Yeah, thank you. Thanks, Chair.
Thank you, Deputy. Deputy Burke, you're next.
Thank you very much. Thank you for your presentations and for the work that you are doing in this area. It's very much appreciated. I suppose one of the things I just want to check in, it's about our educational system. And, you know, we've done a lot of reform in the education system over the last 30 years with, you know, identifying areas where there's a need for more supports, especially in relation to additional teachers, additional SNAs. But then have we actually developed that connection between the schools and the parents as regards giving support to children? I'm not sure that we have done, and I'm talking about in particular, say, in DESH school areas, that while there's a lot of work being done within the school, the connection then between the school and the support that the parents need. And if a lot more was done in that area, then could we end up with a better end result? I mean, I think one of you already in your presentation talked about intergenerational continuation of the problem that was there. But that happened previously in relation to, say, for instance, unemployment. And as a result of a lot of work being done, we've actually made a lot of progress in that area where people, I mean, I was involved in a project, for instance, where we had young people who would have dropped out of school, would have got to the attention of the Gardaí, and we found when we did a survey of people that had been with us 5 years earlier, over 70% of them were now in full-time employment, where there was at least 2 previous generations of the family had never worked. So likewise, if you can make progress in that area, surely we should make a better effort as regards making progress in this whole area as well.
I'll just say something briefly, and then maybe ADHD Ireland might know more. In terms of what we're calling here is the whole school approach. So I have done research on whole school approach. So when you want to bring in a change, whether, you know, in terms of children's lifestyle or eating habits or ADHD in this case, you need that whole school approach. Because, you know, the classroom is so many hours, but then the child is going home. And if the child is getting, you know, if the parent isn't informed. So, I mean, again, if you're talking about actions and accountability and the next drug strategy, you know, we could bring in a study on a whole school approach in terms of developing ADHD, whole school approach in DESH Band 1 schools, for an example. That could be an action. You could see if the pilot worked, you know, and what were the outcomes, and do a long study on that, what happened to those children. Because you're absolutely right in terms of, you know, children dropping out, and then we've addressed, you know, our education with all of the, you know, employment is so much better now. We've got so many opportunities for different ways through education. We do need to take that sort of approach also with this. Yes, I agree with you.
And then coming back to the education system in relation to getting the message out there within the education system, are we giving enough support to the schools for them to get that message across? And could we be doing a lot more with it? You know, in the sense of, you know, advising of the risks that are there. And while certain young people, you know, many young people are very much aware of the risks, but a lot of young people are not aware of the risks. And we've already seen that in simple area like vaping, for instance, where people have ended up with health issues as a result of vaping. Not sure if we're doing enough in that whole area in relation to drugs then as well, that once you start, there's always the risk that you can get addicted at a very early stage.
Before maybe ADHD Ireland answer, in terms of sort of prevention, the positive message is actually reinforces the strengths of the child. So in terms of, you know, in terms of ADHD or whether it's substance use, it's about building resilience in terms of substance use for the children, so they feel, you know, they know how to say, no, I don't want to have a beer because I have Gaelic football tomorrow morning, you know, or my dad's picking me up. So we build resilience based on strengths. So it's similarly, I'm not an expert in ADHD specifically, but I do know something about the whole school approach, and the best way for prevention is building on the strengths of the child. But that takes the whole school approach. And, you know, I'm sure ADHD Ireland would like to say what they think should happen in the schools in relation to that.
Just 10 seconds before I hand over to Sonia on this. You know, recently we changed our slogan. It's now support, education, and acceptance. And the acceptance is the large part of that. Acceptance means you got to move somewhere and do something. Just very quickly, in terms of, you know, we've presented our position today is that, you know, substance misuse is part of the bigger picture with ADHD in society. And to improve that, where does that start? For us, it starts in schools.
Yeah. Just one other issue I just want to touch on. You know, the makeup of the population has changed dramatically in the sense of, you know, we've so many people in from a large number of countries. You have some schools who may have, you know, 30 to 35 different nationalities in the school. Is that going to prove to be a further challenge now as regards, you know, where young people are finding, trying to blend in with the education system here and then trying to work through additional challenges that they have because of, you know, they may have had difficulties in the countries they were living in previously. They've come to Ireland. Okay, while there's a lot of supports, is this going to be a new challenge that we are now having to face as well?
I'm a big supporter of multi-denominational education and that educate together kind of ethos. My own eldest child attends an educate together school. I think there's huge benefits to being educated alongside your neurodivergent classmates, your classmates that are from different cultures and different traditions. I think that builds strength as a society. It builds empathy, and it fosters that acceptance piece that can then be brought forward into other aspects of society outside of the school system, so that whole school approach. I used to work in the School of Education in DCU, and I worked in the area of inclusive education. One of the programs that I was involved in teaching was reflective practice for student teachers. And one of the exercises that I would have them do is to draw a classroom and themselves being represented as the teacher within that classroom. Without exception, every year, the students would draw themselves at the top of the class with students being seated in desks around the rest of the classroom. We've changed so much with regards to how we provide healthcare, with what our workforce looks like with regards to teleworking and things like that. But if you look at pictures of schools that were in existence back when they were first formed in the industrial era to what they are now, very little has changed with regards to how we conceptualise how education is delivered, despite the lovely changes that have happened within the curriculum over the years. Those schooling systems do not suit a large proportion of learners within the classroom. They suit the majority, yes, increasingly a smaller majority as we grow and develop as a society. The idea of English as an additional language within those schools, kids that are experiencing mental health concerns, kids who are neurodivergent, for a large part, the most traumatic thing about their childhood is their engagement with the education system. And that's a failure on us to adapt our education system to a universal design approach where every child is respected for their unique learning abilities and talents. And I don't think we do that well enough yet.
Okay. But I suppose where I was
Deputy.
asking the question is about, say, for instance, you've a parent
Deputy,
where a
I'm sorry.
child has run into a particular problem, that parent not knowing where to start as regards getting access to support. And I suppose that's one of the issues that I'm raising, because they've come into Ireland, you know, children are very young when they come in, and they may not have access to the service. And I'm just wondering, are we doing enough in that area to make sure that people can access the services to get that support?
I think on that point, I think one of the challenges that we're having across the country is that the supports just aren't available, that every support is overrun currently, and there isn't a service in this country that's without a wait list for child access. And I think if you were to implement any sort of preventative change, I think that issue of access needs to be addressed first and foremost.
Thank you. Thank you, Deputy. We'll do a second round. It's myself now on the road, and firstly, let me just say apologise for not being present at the beginning of the meeting. There was a meeting of committee chairs with the Taoiseach, so I had to represent this committee there, so apologies. This has been fascinating, really has been. I suppose my first question is, there's no economists here, and so within that it's going to be a very unfair question, so feel free to treat it as such. But how much does a society that is so possibly becoming increasingly more informed about neurodiversity, ADHD, probably has good policies but terrible implementation, how much would they reckon that actually cost the state in crude terms? Excellent. Thought you might get.
There's been lots of international surveys done on this. There was the original one was the DEMOS survey done in 2018. Have I got your attention? So what they did, they took the ethnographic information from Denmark, because every time you sneeze over there, it's recorded somewhere. So they were able to show that the economic cost, or the socio-economic cost, was about €17,000 per person. If you use the figure,
a population similar to our own.
Sorry?
That's in a population similar to our own?
Yes.
Yes.
Yeah, so 17,000, but if you take about 105,000 adults at the lower percentage, you look at 2 billion a year. We've currently just finalised some research with UCD and HSE on the socio-economic costs in Ireland. We haven't published yet, but it's imminent. So again, that's coming out much the same figure, I'm afraid. So the socio-economic cost in Ireland every year for undiagnosed, untreated adult ADHD is about 2 billion.
That's extraordinary.
I'm afraid so.
And then the human cost. So if you think,
Yes.
and again, I'm going to push on the human cost.
Yeah.
So the human cost in terms of, obviously we're talking about more prevalence of addiction, marital breakdown. Please continue. Yeah.
Well, just 10 seconds. We mentioned the research there around suicide, and 20% of adults, 160,000 adults, have attempted suicide. 50% are self-harming. We know just in the figures on substance misuse, we know the prison rates. We know that they're going to have higher rates of anxiety and depression, other psychiatric conditions. The personal cost is huge, and I'm afraid we're not doing anything about it as a society.
I'm going to quote back to just kind of a consensus statement on the evidence around ADHD, and what they said was people with ADHD are at increased risk of obesity, asthma, allergies, diabetes mellitus, hypertension, sleep problems, psoriasis, epilepsy, sexually transmitted infections, abnormalities of the eye, immune disorders and metabolic disorders. And we haven't even got to the psych ones yet. People with ADHD are at increased risk of low quality of life, substance use disorders, accidental injuries, educational underachievement, unemployment, gambling, teenage pregnancy, difficulty socialising, delinquency, suicide and premature death. And then if you take all those people, 170,000, I think you said was the rough estimate of adults, they don't live on their own. They've got parents, they've got children, they've got employers, they've got family and wives and partners. So the social cost of this is huge when you bring out all those kind of potential negatives for different people out to their wider community.
It's extraordinary. Katrin?
But what are we going to do about it?
Well,
all right, so I'm the practical person here, right?
Not my job.
Yeah. No, we're going to use the resources that we have, and we have, you're here because you're going to be looking at the National Drug Strategy, so we need to make sure that there is an action in there, responsibility to the Department of Education, the Department of Justice, the Department of Health, that there is an action. It only takes half a sentence, but I know that words, are very, very important. If we can get those actions in there, and let's start with something that we can do, And one thing could be, you know, the Department of Education bringing in something about neurodiverse informed or some sort of a study to look at this whole school approach and follow that through.
It's a really good suggestion. So this committee was initiated following the Citizens' Assembly on drug use. Our remit as a committee will be to deliver a report in June that will present to the government, and so what would disappoint you massively, given all of the effort you've given to come in here today to share your expertise? What would disappoint you massively if we didn't include in our report?
Great question.
We're working, you know, forgive me, but, you know, we've seen a huge amount of greater stakeholder engagement with ADHD Ireland, you know. I was recently appointed by the Minister last September to the Expert Advisory Group on Suicide. We mentioned we've been talking with the CSO around how you'd redevelop disability service part of the census next year. I'm on the National Oversight Group for CAMS. We are getting at the table, but it's only in the last couple of years. I would hate to get to a point where we're now getting at the table, but we're still just being, you know, not saying, you know, you got your point in, well done, Ken, but we didn't put anything into the document, as Catherine was saying.
And what would disappoint me? You're sitting here as well as us, and you're here longer than us. I would want your report to be included. Who is the decision maker? We can make recommendations, but who makes the decisions? I think, you know, that's where we need to focus on. Where is the decisions being made about inclusivity, of voices, of actions in the National Drug Strategy? You know, I love the work you're doing. I admire the work. You're sitting here, and I know you're busy people, and we're busy people, and we're sitting here because we care. I will tell you, I am missing my Christmas lunch to be here.
Oh,
that's how dedicated I am.
We'll speed things up, I promise.
Right? No, it's not that. I would rather be here with you, but we need to make sure that, you know, your voices from your report get transferred into the National Drug Strategy in terms of measurable actions. Full stop.
Like Lynn said earlier, I'm a medicated ADHD, and the reason I can stay here for 2 hours, which I probably wouldn't have been able to do 2 years ago, it's because of the medication I take. But I suppose once you become conscious of the world that existed in my own life previous to being diagnosis, medication, understanding that a lot of what I would have experienced would have been helped by an awareness earlier. That was on an individual level, but like on a statewide macro level, I mean, once you become conscious of what Ken just said in terms of 180,000 people, the prevalence of all of the issues that you leveled out, Philip, I mean, once you become conscious of that, the world sort of changes a little bit, and you have to be able to react to it. So I suppose that for me is where the job of this committee is in terms of, just all of us, in terms of turning this into something concrete.
Yeah.
But is there anything you haven't been asked yet, or anything you'd like to say, just in terms of the brief time I have left? And then we'll go for a second round.
Just a very quick comment, and just to say thanks to yourself and Lynn for saying that you do have ADHD, because one of the things we always talk about is role models, and to normalise ADHD in society, we need to see people that do have the condition coming up and saying, yeah, I have ADHD, but I'm getting on with my life. Because just to say, we are talking about challenges, but just to say, as we did say a couple of times in our statement, it's not everybody with ADHD. And forgive me if there is an old saying, just, you know, very quickly, someone's talking about it, you know, in America, ADHD index massively in 2 sections in American society: millionaires and the prison population.
That makes total sense. Yeah, as grim as it is, that makes total sense.
We have a choice.
Philip?
I'm just thinking about that comment and just in terms of stigma around substance use service. Now, we're here primarily because we want to represent clients with substance use services, and I know we have kind of effectively dual privilege here, but I don't think many members would want to declare that they use cocaine or use cannabis in this, because that's even more stigmatised in ADHD or most of the mental health problems we have. It really casts people under a shadow that can affect their employment and their livelihood, and that becomes a reality when they go to attend services. If they're known to have a substance use problem, whether it's maternity services, whether it's medical services, or whether it's child and adolescent or adult mental health services, it casts a shadow over their care.
Thank you, Phil. We have a second round of 4 minutes, so...
Yeah, in fairness, I was going to come in with that piece in relation to, you know, those with ADHD, because you probably, like, we're all aware of certain outlier characters and the Michael Phelps type scenario, and I suppose he can make really good use of, you know, that hyper focus and when you have an interest. And here it might actually have been interesting if we had actually put the chair up there and we could have asked him a couple of questions as well in relation to what he just said, because I think, I suppose it's vital that we have a system, in fairness, back to the all of school approach, because in the Disability Committee we had Corpus Christi Primary School in Moyross. The principal's Tiernan O'Neill. It's a pretty outlier school, and it was the services as regards therapies, but it was also the psychologist. It was all of that. It was having everything in the same place. You know what I mean? And you get to deal with an awful lot of the issues. And I suppose that's the system we need in general, you know, to facilitate people. So it's that idea of the Portuguese model again, where they pulled out the services out of special schools, put them into teams, and then put it across mainstream. So it just meant everyone benefited from what was needed, you know. And again, you were able to get people early, so therefore they mightn't have needed as much later. Because the thing I had got when I had heard this, first of all, I said, yes, screening's the important thing. Obviously, if you have ADHD, an awful chance that you're going to fall into addiction. But I did sense that there was almost an over and back, a two-way thing, in the sense of, yeah, provide the supports, provide the resilience training. That might not be the case, but there's also an element, I would say, of, you know, when you're talking about the impulse control issues and all the rest of it, that there is still a predilection towards addiction. And
most psychiatric disorders pretty much make you more likely to develop a substance use disorder. ADHD starts in childhood.
Yeah.
It leads to increased impulsivity. So it's not rocket science to figure out that obviously increased impulsivity in the teenage years is probably going to make you more likely to try substances. And usually people who have a mental health problem who start using substances are more likely to develop a problem with that, a substance use disorder. The MCDDA that Catherine mentioned earlier on that she was involved with, they recommended years ago, I think it was 2011, that children attending CAMS should be seen as a higher risk category for developing substance use disorders and should be screened appropriately. And I know there's a lot of work done between the addiction services or substance use services that are available for teens and the CAMS. Again, in lots of places, they're very separate services, and that does make that difficult.
I was going to say that we know the whole issue, you know what I mean, whether it's disability, whether it's, you know, CAMS, and you belong here, you don't belong here.
Yeah.
And some of that, there's constant conversation about improving that, but it's still, everything exists in its own silo, and we're dealing with multiple comorbidities before you even take addiction into play. You know, so it's a better all-round system. It's not just an all of school; it's an all of society. You know. Yeah. So and again, your big ask here is that first and foremost that we're going to talk about an ADHD or a neurodivergent informed thinking across the board. So it's just an absolute necessity that we get within the National Drug Strategy the lines, and again that's reinforced in every department that it crisscrosses over. Yeah. If anyone else just wants to go into whatever else we need to do in relation to improve this, and I think it's absolutely vital, not only the training and everything, that we have follow-on research that we can actually present, because I think that will be phenomenal.
Rory.
See, I just talk and ignore. I assume you'd have an ability to do that.
I'm going to pass. I might just pass on to Deputy Grant, so we will come back to you, and if that's okay, Deputy Morgan.
Just very quickly, Phil, because I ran out of time on the last round for you. I was really interested what you said about the World Health Organization and the American Psychiatric Association referring to addiction as a psychiatric disorder. So if we were to embrace that, do you think then that the government policy is basically punishing people with psychiatric disorders if they're drug users?
Punishment is probably, there has been a trend in many countries to
criminalising them.
To criminalising?
Yeah. So if they're criminalising drug users, do you think with that
I think this is a complicated one. At the moment, some of my research is about people accessing treatment quickly when they develop a substance use problem.
Yeah.
And one of the quickest routes people access substance use treatment is when they come via the court or the criminal justice system. So there's laws of unintended consequences here. If you decriminalise it, that might mean those people end up taking longer to access treatment. That's hard to measure. That's hard to do it. So I don't have a nice answer on the logistics of the law.
It's a difficult
It's not an easy one.
Become a criminal and you'll get access and don't.
It's not even that. It's that a lot of people, for example, who are using substances problematically, alcohol being a very good example of this, don't realise they have a problem. And if they turn up for treatment, so the example I use a lot in education is you have a 20-year-old guy who, for example, goes out some night, his girlfriend breaks up with him, he goes drinking with the lads, he feels really down and he thinks about taking his own life and he gets brought to A&E, which is what happens. The next day he's mortified, he sobers up and basically, because he was intoxicated, he's told, well, you don't have depression, what you have basically is a substance use problem because that's what triggered you ending up on that bridge, and he's sent away to a substance use service. He doesn't believe he has a substance use disorder. He's never going to go to that appointment. He thinks he has a girlfriend dumped him problem. And the problem is our segregation of services means people's problems are broken down into these separate silos, and if they don't agree with the silo we put them in, they don't get help. And that's before we get to the waiting list.
Can I add to that?
Yeah.
Is that okay? Yeah. I'm aware of Philip's research because I'm working with him on it. His research also shows that people do not get transferred into addiction services through the schools, not at all.
Yeah.
But in other countries they do.
Yeah.
So our schools just don't have that sort of level of awareness at all. You know, we've done an international literature review on that, and your work has shown that, you know, in Ireland, it's ridiculously low, the amount. So somebody shouldn't have to go through the judicial system. I don't want my child going through the judicial system if they've tried cannabis or whatever, or their electric picnic or whatever. Yeah. You know, you want the schools to pick up, why is that child late? Why does that child look half asleep? What's going on here? And it's not happening at the schools. Yeah. You know.
And then secondly, and very quick questions, we've been discussing for a number of years the HSE having a dual-based diagnosis. And just based on our discussions today, do you think that should now be kind of a triple diagnosis? So, you know, addiction, mental health, and neurodiversity, ADHD, etc. I think so.
I actually, in one of my earlier drafts of this, I wrote that we'll end up with a triple diagnosis service, but I was afraid to mention it because I was fear people would take that as a good policy idea. Because what if you take it, at least half of the people who attend substance use treatment services have a comorbid psychiatric disorder. Yeah. Okay, 20-odd% is ADHD, but there's lots of others. And so, in theory, we will end up with a situation where the people attending the generic substance use service are much smaller than the people attending the specialised dual diagnosis service. And that's before you get into the number of people who are currently attending mental health services who also have maybe a substance use problem that's not clearly identified and getting addressed. So, I mentioned earlier on the service in Australia, the Origin service. My personal belief is the more siloed we get, I have a concern about that because there's more cracks for people to fall through. Yeah. I like the idea of a service that says, we're here to help you, what are we helping you with? Yeah. And sometimes you discover things that you didn't know. So someone arrives for, like that 20-year-old guy I described arrives for a mood problem, and in the back of it you're going, okay, there's some substances here as well. Yeah. Okay. And it's a whole person approach.
Thank you.
Thank you, Deputy Grouse. Senator Nicol?
Thanks very much. I wanted to pick up on something that Senator Costello brought up earlier about education and awareness and for parents, because I have spoken to some people who, when a child that they know or a child of their own gets a diagnosis, that they're kind of reticent around the introduction of medication. And I think that's just, again, I think it's just a stigma thing. I think it's just a lack of awareness of the benefits, but also like not everybody takes the same dose. Like, not everybody needs the same dose of a medication. And I think sometimes, and like we've seen in popular culture and movies and stuff over the years, where it's kind of thrown about, you know, the name of the drug is thrown about, and it's kind of referenced in a really negative way. And again, that's just stigmatizing it. So how can we better inform parents, but just wider society around the proper use and respect of medication for ADHD?
Just very quickly on that, we've been working with a couple of organisations. We actually have a whole set of videos on our website on how what is ADHD medication, how you take it, things like that. So we have those tools there that are working. But we know from our support line that there is a stigma around taking ADHD medication, and there is a reluctance among parents. And certainly there is that education deficit. But as we were saying, medication can be part of the treatment protocols for ADHD going forward. So.
And are GPs readily, sorry, before you come in, Sonia, are GPs readily signposting your videos to parents? Like, is there a connection there between, because the first protocol is often a GP, so if there is an unconscious bias on the part of a GP, does that get passed on? So I'm just wondering, is there signposting there, and are people directed to your website by way of?
What we find is, forgive me, in the ages of 8 to 12, that 4 times more boys than girls get diagnosed. ADHD, we mentioned, is genetic, so 60% boys, 50% girls. Why are girls not getting picked up at that age? Because it's not being seen.
Because it
don't
presents
recognise
differently, doesn't it? Does it present differently?
It does. But that's it. The girl's sitting out in the clinic and she's being quiet, not causing a problem. And the GP's going, she's quiet, girl, can't have ADHD.
Yeah.
But the GP, we've been working with the Irish Council of GPs for the last number of years. They did some recent research and they asked GPs, what's your number one training need? GPs are now saying it's ADHD. Because you mentioned that 50% of people going into the HSE are looking for it. So they're coming through the GPs. A lot of people coming into GP service going, I think my child might have ADHD. And GPs need that training.
Yeah.
So as part of the new integrated plan for adults, one of the levels we're looking to put in is GP training within that. So there'll be 3 levels of training. So GP 1 will be just, I know and understand what ADHD is. 2, I'm able to describe. And 3 is being able to diagnose. So this is something that is coming in the new integrated plan for adults. Now the plan is, we've received it from the consultants. We've approved it as a board with ADHD Ireland. It's currently going through approval process with the HSE. But obviously just, we mentioned earlier that the HSE does have the clinics, but they're all understaffed and undermanned. So, we will have a new plan, but it's getting it enacted is the next challenge.
Yeah, it is hard to get an assessment, I believe. Sonia, publicly, I think a lot of people are paying a lot of money to go privately for those assessments.
So. And the private sector is completely unregulated at the moment, with no national guidance on what a good ADHD assessment looks like, which is a huge challenge. In answer to your question about signposting to resources with regards to medication, I think when people present to the GP, it's with the question of, am I ADHD, as opposed to further down that line of, okay, now I know that I'm ADHD, what are the supports that are available to me, and considering them. So I think the focus on GP education is more that level 1 to begin with of, what is ADHD? Am I confident as a clinician to be able to recognise and support an individual in front of me with accessing the right service to figure that out for themselves? And I know from many adults, their personal stories is having gone to the GP and saying, listen, I think ADHD is true, and it being shot down by the GP because of a lack of understanding of the diversity of presentation of ADHD, like Ken had highlighted there. So preventing that would be a key piece. With regards to the stigma around medication, I do think that there's a lot of work that needs to be done with regards to that. Again, the access to services piece comes up again because there's no point in, garnering widespread acceptance of ADHD medication if people can't access it in a speedy way. But I also think that for those people who are quite adamant that they're not availing of medication, that there be an alternative treatment option available or supports available. And at the moment, what we have is we have ADHD confined to just Tier 2 or Tier 3 mental health services, with very little available at a primary care level. So I think that needs to be developed too.
Great, thank you.
Thank you. If anybody wants to come in and ask any more pressing questions, we want to get Catherine out to our lunch. Yes.
Can I just follow up just about the parents and kind of, saying CAMS coming, that if a parent is told, well, if your child isn't going on ADHD medication, you can't come to CAMS, and they're, they don't need us, basically. But if they come and they're attending, for example, OT or social work or whatever other psychology, whatever other services are there, they may revisit that because we're now engaging with this parent to help their child. And the concern I always have is that people are outside services. you know, and so I think that if a parent is coming who is looking for help, let's meet them where they're at and talk to them about what's going on. People change their mind and people take different views. Some kids won't ever need medications, some kids will, and that's a journey. It's not something that needs to be put at the first meeting or the second meeting.
Yeah, I'm fairly sure this, well, first and foremost, right, you're saying that the new integrated plan, that will mean like your first protocol will be the GP? Or it just mean, or it's there?
Just in your previous questions, you were talking about, you were getting onto a single point of access.
Yeah.
So I don't know if Sonia wants to talk about single point of access, or do we have enough time for that?
Well, the single point of access is child services, whereas the integrated model of care is adults. They wouldn't necessarily cross over, but the new adult integration model of care is, I suppose, is a revision to the previous model, which hasn't been effectively implemented for lots of different reasons. But I suppose it's to take the pressure off those specialised adult ADHD teams. There's a real reluctance at the moment for GPs to prescribe ADHD medication. It's seen as the remit of psychiatry, and I suppose this change in the model is to encourage more GPs to get more involved in ADHD care and management and support. So that's a welcome change as far as we're concerned.
No, definitely. And I suppose the big follow-up on what I had said earlier was the idea, because like we've gone through, right, getting the lines in a national disability strategy, and then it's the means by which we put a more fit-for-purpose, all-inclusive, you know, system in play. Look, in fairness, the idea of doing it in schools or even before it, and that you're catching everything as you go along, right, that's perfect. And then beyond that, I suppose it's building up that evidence base. And I suppose I doubt there's any evidence in this stage in relation to, you know, those that have got the supports and whatever, and as regards, the change in percentage in relation to those that fall into addiction, you know what I mean? Because that obviously would be absolute, you know, rocket fuel from that point of view.
So, very quickly, just 10 seconds. What we do know about ADHD, and we've talked about all the challenges around substance use, suicide, etc. But when you get the right treatment, outcomes improve. All the research shows that, you know, whether it be medication or a combination of OT, speech and language therapy, once you get the right services, generally, outcomes improve. You can severely impact someone's life by getting the right treatment at the right time.
Just to quote the research again, I love quoting research, I apologise. Treatment with ADHD medications reduces accidental injuries, traumatic brain injuries, substance abuse, cigarette smoking, educational underachievement, bone fracture, sexually transmitted diseases, depression, suicide, criminal activity, teenage pregnancy. The sooner we get people treatment, the better. And I mean, ADHD is very clear. It starts before 12. You know, depressions and anxieties and psychosis don't.
Yeah.
You know, people are ending up with no diagnosis in adulthood because the system has failed them. We haven't picked them up, whether it's in school or whether through their families or whether through other organisations, you know, but we haven't picked them up and they've ended up as adults and they faced those consequences because the system is failing them.
And just the last thing I would like to add to that is we're talking about ADHD here, but you know, when we did the research, we actually went looking for ASD as well. Yeah. We didn't find any literature on that. All right, I think there was 1 or 2 papers. So when I wanted to do, you know, an international comparison on the numbers, the literature literally was not there amongst people who are using drugs. So that was really shocking to me. Now, we got people responding in our survey, but we didn't see it in the international literature. So if you are going to put any actions in, while the majority is the ADHD, we have to also remember the broader neurodiversity as well. Let's not forget about that.
That's it. But when we just take the whole bracket of neurodiverse, we don't have a sufficient amount of research done, and even the fact we have disparity in relation to the percentages, you know, the 21% versus 51%, and you said in some instances even
it's
higher.
It's up to 60, in the prison setting, and that was the ADHD, but nothing on ASD. You know, we have it in our study here, the ASD was, I think, about 30-something%, I can't remember now just offhand, but very little in the international literature, practically nothing.
No, so
real need, practically nothing.
We have to finish up. Thank you so much. Thank you. Honestly, that was really informative, and I think all of us who've listened come away with a sense of what we need to do as a committee as well in terms of how this shall be recognised. So thank you all for your contribution and your expert testimony. Thank you. This meeting is adjourned until the 18th of December at 12:30 p.m.